Okay, so I want this to be a little bit provocative, um, and I guess my disclosures would be that I've been working with a Gamma knife now for this is actually going to be my 25th year. And of course, with Gamma knife, we typically don't add margins, so I'm a little bit biased against margins. Um, but let me just share with you my talk and my understanding of the literature and where we are in adding margins for SRS treatments. So we all know the classic definitions of our GTVR, gross tumor volume, and then we enlarge that a little bit if we think that there is some subclinical malignant disease. Note it says malignant disease there, so I would argue that there's really very little justification from going from a GTV to a CTV if we're talking about the treatment of benign disease. Maybe you could have a complex hormonally active pituitary adenoma, where you can see a GTV, but due to previous surgery, you might want to include a little bit more. You could argue that that's a GTV to CTV expansion. And then after that, we then can enlarge the GTV CTV to a PTV, and that's to take into account any inaccuracies in the treatment. And then, of course, finally, we have the plan that we end up delivering, the prescription isodose volume, which is the isodose covering the PTV to achieve the intended clinical effect. And this is actually interesting because the PIV, prescription isodose volume, can vary from one center is happy with 95% coverage of the PTV. Another center will want 100% coverage. I've heard the term 100% plus, which means you're being really quite generous with your coverage. And all of those, that definition is going to change the actual dose that you deliver. So let's go back now and look at what biological justifications do we have to go from a GTV to a CTV in radiosurgery. There's a fantastic paper that I don't think has been repeated by Baumert, where this was looking at brain metastasis specimens and looking to see where there was infiltration into normal brain. So you can see that in the table below. What I think is really interesting here is that the primary disease makes a difference in terms of how much infiltration there is. So, for instance, if you look at melanoma, you can see that there seems to be significant infiltration into normal brain. So the maximum depth is 1.19 millimeters. You could argue that you need to add a margin when you're treating melanoma compared with, let's say, breast cancer, where in the group of specimens they had the mean maximum depth, or the maximum depth was just 0.28, which is just a very, very tiny amount. When you contour a lesion using a T1 gadolinium enhanced scan, you get the phenomenon known as the partial volume effect, and that can effectively enlarge the volume that you end up contouring, because if you've got a voxel and it has just a very small amount of tumor in it, it will appear to be enhanced, and you're quite likely to contour that entire voxel, even though only a small part of it has tumor. So you could argue that in SRS, when we contour, we actually add a little bit of a margin, and that would certainly cover the sort of the amount of infiltration that you have in breast cancer, or maybe the non-small cell lung, where it was 0.63 millimeters. Maybe not for melanoma. Now, the definition of margins, there's a seminal paper by Van Herk, which proposed enlarging the CTV to the PTV by using a formula which was 2.5 times the quadratic sum of the systematic errors and 0.7 quadratic sum of the random errors. And to quote the paper, they say, because this margin excludes rotational errors and shape deviations, it must be considered as a lower limit for safe radiotherapy. So there you've got this concept of a safety margin. And I really don't like that term in radiosurgery. In radiotherapy, where your prescription dose is less than the tolerance dose for the organ that you're treating, there's really very little downside to increasing a margin, and therefore that's fine. But radiotherapy is not radiosurgery. In radiosurgery, our prescription isodose is much higher than the tolerance dose of the organ that we're treating, and in the case of brain, very much higher. And there's no such thing as a safety margin. We pay a price for adding a margin. So what kind of movement do we have? This is very interesting video. This is looking at subvoxel motions in brain tissue. I can get this to come up. What we're seeing on the left is movement of the brain. Very, very subtle. On the right, what we're seeing is amplified motion of the brain. So what you're seeing on the right makes it more conspicuous, but it's not actually to scale. But certainly the brain does move, and we need to take that into account. And there have been some studies looking at that. So in this study, you can see that different parts of the brain move with the cardiac cycle, up to 0.18 millimeters for some tissues. So relatively small, but still, this is even if you've got a frame, you're still going to have some movement. You've also got to consider the optic apparatus moves as well. If you're treating, let's say, a meningioma up against the optic nerves, that can be significant, and there needs to be some provision for making sure that the patient's eyes are in the same position for imaging as they are for the treatment. And there's a paper from the group in Stanford that looked at the movement of chiasm. So they performed sagittal and coronal scans through the patient, looking in particular at the chiasm, and they find that the displacement, is somewhere around 0.5 millimeter. What they therefore recommend is that because this can effectively increase the chiasmal dose by 14%, you should maybe enlarge the chiasm as an OAR or avoidance structure. Now, I would argue that chiasmal doses are empirically derived from SRS treatments where there's always been this kind of movement and this variation. So, I think to a certain extent that's already built into our tolerance doses, which I think are still very, very low for the optic apparatus, and probably the true tolerances are a bit higher, but that's another controversial subject maybe for another time. And of course we have machine related errors, and particularly if you're treating with multiple targets with a single isocenter, we know that the further the target is away from the isocenter, the greater the relative dosimetric error. So, we do need to take this into account. Of course, that varies depending on where you are relative to the isocenter. So the concept of having multiple margins I think makes a lot of sense if you're treating with a single isocenter. What we need to understand in radiosurgery is that we have a high dose gradient both inside and outside the target. That's how we manage to get a steep dose fall off. That's how we manage to be able to deliver radiosurgery. It wouldn't be possible unless we had that steep dose fall off. And so on the left, we've got a target that we're covering with a dose without a margin. If we add a margin, what we effectively do, assuming that the target doesn't move as much as the margin that we've added, we are certainly increasing the effective dose to the target, and we're delivering a much higher dose to a volume of normal tissue. And if you recall in the first slide where I was talking about the prescription isodose volume required to cover the PTV to achieve the desired effect. If you're giving, let's say, 95% coverage of your PTV, then you're effectively giving a lower dose than you would be if you were, let's say, covering 99 or 100%. So this is very important to take into account. Now, this is two dose plans. On the left, we've got a CyberKnife treatment plan of a vestibular schwannoma with a 1.25 millimeter margin. On the right is a gamma knife treatment plan with no margin. You can see that what I'm showing here is just the GTV outlined in red and then the prescription isodose in yellow. I can tell which plan I would prefer to have if I had a vestibular schwannoma. It would be the one on the right. The one on the left looks very sloppy, but only because you've got a margin. It's not got to do a lot with the fact that it's a CyberKnife. So we should really talk about this as a margin treatment versus a no margin treatment. Now, the group from UCSF and from Sunnybrook looked at this in relation to gamma knife treatments. This was around the time when the gamma knife was being geared up for the release of ICON, where you can treat patients in a mask. And therefore, people started asking, well, now we're treating in a mask instead of a fixed frame. Should we be adding a margin? So they looked at 15 clinical targets. Each were planned multiple times with margins between 0.5 and 3 millimeters. And then they used the symptomatic radiation necrosis model, that's Flickinger's model, to calculate the risk of symptomatic radiation necrosis. And they found, for instance, that a 2 millimeter margin on average increased the volume, the overall treatment volume, by 55%, and the risk of symptomatic radiation necrosis between 6 and 25%, depending on the volume of the target. And you can see that here, the V12 increases as your margin size on the x-axis increases. I suppose that's fairly obvious, but when you look at it in terms of risk to symptomatic of radiation necrosis, then that's really quite significant. And here we see the relative risk on the y-axis versus the volume of the 12 gray on the x-axis. So here a 2 millimeter margin added to a 2 centimeter diameter target treated to 18 gray will increase the risk of symptomatic radiation necrosis by 25% if you're using Flickinger's model. The team at UCLA performed a similar study. They looked at 51 targets in 8 patients, and they planned these targets with no margin, 1 millimeter, 2 millimeter margins, and then also a variable margin protocol where it was 0.5 millimeters when treating multiple targets with a single isocenter, but those targets that were 6 centimeters or more away received a 1 millimeter margin. And what they found was that the V12 and various other volumes approximately doubled when margins changed from 0 to 1 millimeter and tripled when changing from 0 to 2 millimeters. With the variable margin protocol, they found that it was actually the V12 was similar to that of the lower margin, the 1 millimeter margin results, since only 12% of the targets were more than 6 centimeters away from the isocenter. So what they concluded was that they switched their modus operandi from 2 millimeters to 1 millimeter as a result of this study, with an eventual goal of using 0.5 and 1 millimeter variable margins, depending on the distance of the target from the isocenter. So what does this mean in terms of, these were theoretical studies, but there are at least a couple of clinical studies. So there was one performed in Paris a number of years ago, where they looked at radiosurgery with or without a 2 millimeter margin for a series of single brain metastases. And what they found was that the no margin group, the incidence of severe parenchymal complications, as they described radionecrosis, was 7.1% in the no margin group and almost 20% in the 2 millimeter margin group. And that was statistically significant. But interestingly, the local control at 1 year was no different. And then there was the Duke study, which was more recent, where they randomized 80 lesions in 49 patients to include a margin of 1 millimeter or 3 millimeters. And in that study, they found that there was no difference in local control. The study was halted before statistical significance was gained, but they found that they had 5 incidences of radionecrosis in the 3 millimeter group and just 1 in the 1 millimeter group. In a retrospective analysis of 121 patients treated with 2 millimeters versus 0 millimeters, they found no statistically significant difference in local control or, interestingly, in pseudo-progression, although this was a relatively small group. And in another study, a European study, where they looked at a large series of brain metastases treated either with a single isocenter per target versus those that were treated with a single isocenter for multiple targets. And both groups had 1 millimeter margins. But they found that the 1 year freedom from local recurrence was 87% in the single isocenter per single target group and 94% in the single isocenter versus single isocenter treating multiple targets. So they said that local recurrence-free interval was not associated with the distance to the isocenter. And clearly, as you're getting further from the isocenter, you're getting less accurate. You're less likely to cover the whole of your target. And yet here, it doesn't seem to make a difference. So why is that? Is it that the doses that we're actually prescribing are higher than they really need to be if we're covering all of the targets? So even though we're maybe prescribing 20 gray, maybe we just need to give 15 gray in order to achieve local control. In a group from Japan, looking at a series of just over 100 metastases, in this group, they found that there was no difference in local control versus the margin used. But this was a very small study and not powered really to detect a difference. This is an interesting theoretical study from a LINAC group. So they used the argument that I just made, where maybe we need to we can actually get local control with a lower dose. So they made they postulated the hypothesis that indirect cell kill via devascularization, and you could argue immunological effects, is adequate if you're delivering a single dose of 15 gray or more. So what they found was that if you prescribe 20 gray with a 1 gray margin, you're very, very likely to achieve 15 gray coverage, even if you have a significant error in your patient positioning. And, you know, they argue that that's the reason why maybe SRS works so well for brain mets. But we've just been talking there about local control, but, you know, on the other hand, we have radionecrosis, and we need to try to maximize local control but minimize radiation necrosis. And margins no doubt add a significant amount of normal tissue to your treatment volume, and you will double your volume and treat more normal tissue than target if you add, for instance, a 1 millimeter margin to an 8 millimeter target, or a 1.5 millimeter margin to an 11.5 millimeter target, or a 2 millimeter margin to a 15 millimeter target. And the previous studies have really shown that to be true. Another question that we can ask is how fast do tumours grow, and can we plan at leisure? And the reason I'm asking this question is because some centres claim that a margin covers a multitude of sins, which include potential patient movement, potential inaccuracies in the treatment if you're treating with a single isocenter, but also potential tumour growth if you're imaging the patient on one day and then treating maybe a week later, sometimes 2 weeks later. So here's an example of a patient. We have a cerebellum met at day 0, about 0.8 cc's, but that had almost doubled in 2 weeks. And by day 39, it was 4 times the original volume. Now you could say, well, if we add a margin, we can take into account that extra growth. But in this case, we would have had to add a 2.6 millimeter margin if we were using the day 0 scans and then treating at day 14. The other issue is that isotropic growth can't be assumed. So in this case, if we compare the day 0 scan with the day 39 scan, and we can look here in the sagittal plane, you can see that the inferior aspect of the tumour hasn't moved at all between day 0 and day 39. But the superior aspect has moved 16 millimeters over that period of time. So when you're treating a lesion that's attached to the skull, you can't assume that isotropic growth is going to cover the growth of the tumour. So to conclude, for SRS, margins can add significant dose to normal tissue, and that's morbidity to treatments. And this is really for gamma knife users. You know, is that increase in morbidity greater than the decrease in morbidity that you get from fractionating? That's imagining that maybe you're treating a patient in a frame, you're not adding a margin, but if you're treating in a mask because you choose to fractionate, if you end up adding a margin in that scenario, you might actually increase your overall morbidity even though you're fractionating. So I think that margins follows the dogma that every tumour cell needs to receive the prescription dose in order to gain local control. This is called the target cell hypothesis, and it's rife in radiotherapy, but I'd argue that it's an outdated model for SRS. It seems to be at odds with clinical results, and tumour control is a complex combination of tumour cell death, vascular damage, and immunology. And that curative zone may extend beyond the margin. So margins come at a high price and must be justified if used. And I'd like to thank you very much for your attention.